Today, I'm joined by Dr. Atil Kargi, co-director of the University of North Carolina Pituitary Center and professor of neurosurgery and medicine. He's a clinical endocrinologist specializing in the diseases of pituitary glands, including pituitary tumors, hypopituitarism, Cushing's disease, acromegaly, and vasopressin deficiency, formerly known as diabetes insipidus. His focus is neuroendocrinology, which involves studying the interface between the brain and various hormones that affect many aspects of a person's health. He enjoys the challenge and complexity that comes with treating patients with pituitary diseases. Dr. Kargi also enjoys working with the physicians that make up the multidisciplinary UNC Pituitary Tumor Center. Dr. Kargi, I am happy to have you here. Welcome to Talking Acromegaly with Tony.
Thank you, Tony. It's a pleasure to be here, and thanks for that very nice introduction. That was quite a lot you reviewed in a short amount of time, and I really thank you for advocating for patients, firstly with acromegaly and also with pituitary tumors and pituitary disorders. I'm just so happy to be here, and I've really enjoyed watching your efforts and your. I watch it on YouTube, but your YouTube channel grow, and I'm just very happy to be here and answer any questions um, to have a discussion, hear from you. I'm sure there's things you want to hear from me, and maybe people will leave comments for us, and we can all learn from each other as a community.
Sounds good. I appreciate you being here. With that said, let's jump right into things. You're a pretty impressive guy. Can you share a little bit about what I just went over, a little bit about your background and what led you to specialize in pituitary disorder?
Yeah, well, I guess our first decision point is to go into medicine. So I won't go too much into there. But once, I went into medicine and I was a resident at University of Pittsburgh, I was doing various rotations. And I think that's really when I nailed down that I wanted to become an endocrinologist. And endocrinology is really wonderful. For one thing, we can measure everything, I think, as you know, by doing blood tests and other laboratory tests. And we can titrate treatments to both monitor and control hormone levels as we desire and for our patient's health. And I'd been interested in endocrinology. I know this sounds interesting, but I went to a high school with a special focus on science. And I remember even in high school biology class learning about endocrinology. And even I remember specifically acromegaly in my textbook and, some pictures and diagrams explaining this condition. So it's really a phenomenal, field to be in. It's been growing tremendously. There's a lot of science and, even research and developments in industry and pharmacology and other techniques for our understanding of these disease and how to help our patients. It's an area where as endocrinologists we ourselves don't do surgery, but we work a lot with surgeons and other doctors. But we spend a lot of time with our patients, really trying to understand every facet of their lives. Anyone who's been an endocrine patient or had a hormone disorder can probably remark to how it's amazing how hormones and hormone disorders affect every facet of our life. So we really get to know our patients throughout their lifespan. And also a very intellectual field too, where we do spend a lot of time reading and writing and measuring things. Many of us have spent time in the laboratory as well. So it's really just been a passion of mine, and I certainly don't regret ever becoming an endocrinologist. I think there's also some of this, I guess, if you ask doctors, is a process of elimination too. That there were some fields that I said, I really don't want to be this kind of doctor. I can't imagine doing this sort of work for the rest of my life.
I can imagine. And you are a very impressive doctor. I've got a few friends that you treat. For someone newly diagnosed, you talked about patients. So, why is the pituitary gland so important, and why can disorders of this tiny gland have such a huge impact on our bodies?
Yeah, I mean, I really love how you put it. A disorder of a tiny gland has a huge impact. I mean, the pituitary really is about roughly the size and shape of a garbanzo bean, but it's amazing how many fundamental, important life functions it coordinates. Without a functioning pituitary, we would never grow and develop. So, I also see occasionally some patients who have hypopituitarism and underactive pituitary starting in infancy or childhood, and you wouldn't grow or ever go through puberty without a pituitary gland. The pituitary gland is what we call the master gland. It controls the functions and governs over the other major glands of the body, which I think, most people aren't familiar, unfortunately, with what the pituitary gland is, I find, but they've heard of some of the other glands like the thyroid, the adrenal glands, and the testes in men and ovaries in women. But these glands almost don't function at all unless the pituitary tells them to. And it also works sort of as a thermostat, constantly sensing the internal environment. And there's a word that maybe some remember from high school biology classes or college courses called homeostasis, which is the maintenance of a healthy and constant internal environment, and that the pituitary plays a huge role in that. So therefore, depending on the degree and the variety of disorders of the 7 or 8 different hormones that the pituitary gland makes, people can present with a huge different array of symptoms and medical problems, also depending on at what age and in what gender it occurs. So it really is something that keeps us busy and learning and on our toes throughout our lives.
Okay, okay. From your perspective, why is acromegaly still so misdiagnosed or diagnosed so late?
Yeah, it's true that, it really is diagnosed late. And I really wonder, Tony, I mean, it's sad to think about this, but I really do wonder if we're diagnosing it that much earlier than we did 10, 20, maybe even 30 years ago. We're still diagnosing people late. I can think of a patient we had maybe in the last year, a person who was a doctor themselves and had seen so many different doctors with so many, in retrospect, obvious symptoms and signs of acromegaly, and had tested for all sorts of disorders, including things like Cushing's disease and other things that we see. And sometimes the diagnosis of acromegaly is arrived at in a backwards fashion. So in this patient I'm thinking about, they had headaches, which is a common symptom of acromegaly, and they had an MRI just to investigate the headaches. Not that someone was thinking about a pituitary tumor or anything regarding acromegaly at all, and it just fortuitously they found a pituitary tumor. And probably still that's one of the most common ways in which, once somehow we accidentally back up into the diagnosis by doing a scan of the head, a CAT scan or an MRI, and someone finds a pituitary tumor, then pretty much all physicians, especially endocrinologists, know that we have to check all the pituitary hormones. And even if they weren't thinking of acromegaly quite yet, since the assessments for growth hormone production, those labs are part of a routine panel in that context, it's diagnosed at that point. But I think the causes of it being diagnosed so late are one, that it truly still is considered a rare disease. So it's not that common. I'd have to say that, I'd ask patients and other people watching to ask their physicians they see, how many patients with acromegaly have they ever seen? How many have they seen in the last year or 5 years? And I would venture to say that many of them are going to say, they've never seen any, especially in the last few years, or they may have learned about it in medical school. So it is something that in a busy practice, where especially physicians who aren't focused on this field might not think about acromegaly. Another reason is that the tests we use to measure growth hormone and IGF-1 levels, which we can talk more about, the laboratory testing to diagnose this condition, aren't part of any routine testing panels usually. So someone has to think about the diagnosis of acromegaly and then also usually know what the correct laboratory test is to be able to do it. So it's really just about that light bulb going off in someone's head, whether it's the patient or a healthcare provider who's seeing the patient. And we can talk more about, different avenues that most people get diagnosed with this condition. And so oftentimes, and there are studies of this that have looked at, how many different types of doctors a patient has seen until they were diagnosed, how many years it took, or who was the person who finally, thought of the diagnosis and made the diagnosis. But it oftentimes is taking, on average, we think 8 to 10 years, maybe more. And having seen many doctors with problems that in retrospect were clearly caused by having acromegaly, but not really picked up on at that time and just treated individually until somehow all the pieces of the puzzle got put together.
Understood, understood. Moving forward, when someone is actually finally diagnosed with acromegaly, what should they realistically expect in terms of testing, treatment options, and long-term care?
Yeah, the initial treatment, I think the core of the team would be an endocrinologist and usually a neurosurgeon. And acromegaly is almost always caused by a pituitary tumor. Now, something some people might not know is that there could be really rare cases of other tumors somewhere else in the body stimulating growth hormone or producing growth hormone, but that's exceedingly rare. So for all intents and purposes, let's say that almost always due to a pituitary tumor. And so the core of the team usually would be those two physicians. And in the vast majority of cases, the initial treatment is surgery, hopefully with curative intent. And for that, it is very important, to find a surgeon that's very experienced. And, I saw in one of your previous podcasts, you had a great guest that's known to all of us, a leader in the acromegaly community, Jill Sisko, and she had talked about some numbers about what would constitutes, a high volume pituitary surgeon. And most endocrinologists, fortunately, are experienced and able to diagnose and treat acromegaly. There are some, such as myself, that work at high volume pituitary centers. And, in your introduction, you said that I was a neuroendocrinologist. So that's an endocrinologist who focuses on pituitary disease. And we're always available and usually are linked with some of the higher volume surgeons to see many of the patients. And we sometimes tag team as well, where some of my patients come from far away and they're under treatment with their local endocrinologist and can check in with me as needed if there's some issue that comes up that maybe my added experience or my additional thoughts could potentially benefit. I'm always happy to chime in those situations. But what patients can realistically expect is to have a consultation with the surgeon and the endocrinologist. Something we'll talk about a little bit later is that in acromegaly, outside of the excessive growth hormone levels and the presence of a pituitary tumor that's producing the growth hormone, patients can have a myriad of other medical conditions. They can have other pituitary hormone deficiencies owing to the tumor, and also high levels of growth hormone can cause a whole list of health problems. And really outside of the endocrinologist, I don't know that there's that many other physicians that are that familiar with the different types of downstream effects of having lived with high growth hormone levels for a long time, which we can talk about a little bit more. So in some ways, we serve as a bit of a primary care doctor for certain screenings or triaging some of their medical problems to other specialists as needed, because we're familiar with these specific things that only, come up in the context of long-term care for acromegaly patients that maybe, a primary care doctor that takes care of a lot of patients might not be as familiar with since they don't have many acromegaly patients on their panel.
Right. You have a high volume of acromegaly patients. How many currently do you see?
Yeah, I try to keep some, numbers and lists, and I've been working at UNC for the last 3 years, and I think on my acromegaly list, there's probably somewhere between 60 to 80 patients that we're following. I think overall, I've probably seen or taken care of in the 200 to 300 range of acromegaly. Interestingly, another disease that has similar, prevalence in the population is Cushing's disease, and I have a little bit more of that on my list, but
Okay.
so be it. But in a pituitary center, these are the sorts of numbers that I think the endocrinologist would generally have or see.
What's interesting, my first endocrinologist had one patient before me in her 30 years of practicing. The numbers that you have are astounding for someone like me. Let's get into numbers, in fact. My IGF-1, I'm in range at 244. Can you explain exactly what IGF-1 is and talk a little bit about growth hormone as well?
Sure. Yeah. I'm sure that this is a topic or a concept that interests patients and might confuse them a little bit. So I'll try to back up and explain it a little bit more granularly to make it clear. Um, Acromegaly is caused by excessive growth hormone production and disordered growth hormone production. So the first thing I would point out is we all make growth hormone. All humans do, and adults continue to make growth hormone. And it has a lot of important roles. So there's nothing bad about growth hormone. It's a good hormone. And just like anything else, that if its levels are too high or too low, it can cause problems. Growth hormone is a very dynamic hormone. It has a lot of important roles, but it's secreted in pulses. So as we sit here right now, especially if we had lunch, we're doing this in the afternoon here on a gloomy winter day. Our growth hormone levels are very low usually. You know, uh, so in my case, for instance, it might be zero. Yours may be a little higher, obviously, because of your history. And then every now and then we'll make a pulse of growth hormone, and certain things cause these pulses, like exercise, sleep, certain dietary factors, and so on and so forth. Uh, Now, the issue that occurs here is that if we try to measure a growth hormone to make a diagnosis of who's producing too much growth hormone, it's very challenging to do that because quote unquote normal individuals who don't have acromegaly also secrete pulses of growth hormone. So, if I get a growth hormone level that comes out relatively high, I don't know if I'm looking at someone who doesn't have acromegaly at all, and I just happen to catch them during a normal pulse of their growth hormone secretion. And in fact, I'll tell you, as someone, who, as you pointed out, has seen a lot of acromegaly patients, most patients with acromegaly actually don't have very high growth hormone levels itself. If you measure the growth hormone, it still comes out within the range that's within normal. The difference is that in acromegaly, the growth hormone levels never go down. So those patients with acromegaly, because of the tumoral secretion of the growth hormone, never have the dip down to close to zero that other people usually do. So there's just this constant bombardment or, assault on the tissues of low level growth hormone. And so that brings us to IGF-1. IGF-1 is a different hormone. It stands for insulin-like growth factor 1. And so we call it IGF-1. And it's a hormone that is in part and largely regulated by growth hormone. So it's thought to be a mediator of many of the effects of growth hormone. And in fact, some people might know this, but the old name, and it still is used sometimes, so it's good for our audience to be aware of this. The old name for IGF-1 is called somatomedin or somatomedin C. And so because it's a mediator of the effects of growth hormone, which is also has another name, which is somatropin or somatotropin. Um, so again, IGF-1 is not synonymous with growth hormone. It's not controlled only by growth hormone, but it's probably the best marker we have of the total amount of growth hormone effect there is in the human body. And in fact, many of us would venture to say that there's very few reasons, almost none, to have very high IGF-1 levels. So if I see a lab report and the IGF-1 is markedly high, I mean, I'm talking twice the upper limit of normal, 3 times, 5 times the upper limit of normal, and you're certainly welcome to share with us, if you'd like to. I know you've shared with your audience before how high your IGF-1 levels were before. You told us it was 244 now, and oftentimes it's close to 1,000 in some people. So that's 5 times higher than normal, right? There's really nothing else in human biology or in disease that can cause that. There isn't really another common or rare disease. So that's why the test is so incredibly helpful. And I would contrast it, I know maybe the audience isn't so interested, but there's other hormones like cortisol, for instance, where there's a million different reasons why someone could have a high level of cortisol. But for IGF-1, having a very high level is a very good indicator of acromegaly. Now, I want to make something very clear. A mild elevation of IGF-1 is extremely common in the general population. And there could be many causes of that. And in fact, there's so many people that I can't figure out why they have a mild elevation of IGF-1, but they don't have acromegaly. I can tell them that. But a marked elevation of IGF-1 is almost certainly due to acromegaly.
The day of my surgery, my IGF-1 was 1400. It took me quite a while to drop down. I went from 1400 to 800 to 600. It took me a few years to get my IGF level down to in range, more or less. What are you currently doing for patients um, that you see who are in the beginning stage of their acromegaly? Are you starting them off on any type of medication, or what's the process for you?
Yeah, this is a great question, and sometimes it's debated by experts, but you know, pretty much everyone agrees that surgery should be considered as first-line therapy in all patients. And we do practice by clinical practice guidelines. These are available, they're not necessarily behind paywalls. So if patients were to go online and type in the Endocrine Society clinical practice guideline for acromegaly, they can find algorithms. And it does show there that we should attempt surgery. Though they'll see on the algorithm that there is a line that goes off between the first line down to surgery that says that in some patients, we may consider medical therapy as first line therapy. And this becomes an interesting discussion or debate. Certainly, if based on what we see on the MRI scan and our expert surgeons' opinion, if there's a reasonable chance that we can cure the disease, then surgery should certainly be attempted, and everyone would. The more challenging discussion happens in these cases where these tumors are large and invasive, And a surgeon might say, I can remove a large part of this tumor, but there's certain parts of this tumor that are invading into areas where it just isn't safe, and there's no surgeon that could go and dig that tumor out of that nook and cranny. It's usually an area around the carotid arteries, which go up through our neck and then make a little circle at the base of our skull, right around the pituitary. And so, in those cases, there is a discussion about trying what we call primary medical therapy, trying a medication that can shrink the tumor and control the growth hormone levels. And we can always consider surgery in those cases. Still, in the vast majority of such cases, they still do have a shot at surgery because debulking the tumor can oftentimes lead to improved success in the success of medication. So, again, you can share with us from, your particular case, but if I were to, just use it as an illustration, initially before the surgery, the IGF-1 level, was 1400, and after surgery, it went down to 800. Well, you've dropped it quite a bit. I mean, it's not a 50%, but it's maybe about a 40% drop. It makes it that much more likely that the medications we then add on that shrink tumor and lower IGF-1 can get you down to the 244 goal, which you had. Starting at 1400, it might be quite a bit harder and need more medication, higher doses, maybe multiple medications. And sometimes even with multiple medications, when the starting point is that high, it can be challenging to get down to the target IGF-1 levels.
Yeah, and in the beginning, Dr. Kargi, I wasn't the best patient. I went through a period of denial. I was combative about taking my medication, and I can go on for quite a while talking about that. However, what recent developments or advances in acromegaly diagnosis or treatment are you most excited about right now?
Yeah, I would say that the most, relevant recent advances have generally been in medical therapy. I can't speak too much to diagnostic or imaging developments or surgical technique developments. Maybe others could, but in my experience of about 20 years of working in this area, it's been pretty similar. So we've been very good with our great surgeons at doing surgery, and the acromegaly tumors are generally on the larger side as far as pituitary tumors go. So, advanced imaging techniques haven't necessarily been so necessary. They're usually readily, seen on standard MRIs of the brain and pituitary. So really, I would say that the developments have been in medical therapy with developments of new medications that can treat patients. Also, with some work, though there still needs a lot more work to be done in improving our ability to first, what we started off talking about today is how do we first find and detect the patients, so that we could talk about more about, getting people to find out they have acromegaly. And then also there's been some work, but it's still early in individualized treatments because there are different treatment strategies with medications. There's about in general 3 categories of medicines that have different, mechanisms of action. And when we first see a patient, let's say after surgery, and let's say their IGF-1 levels still aren't completely normal, and we know we may need to use an additional medication to treat them, it's still very difficult to know which medication is right for which patient. And there has been some work in this area, with lots of different approaches, including looking at molecular markers or other characteristics of the patient. But still, it's challenging to know. I still to this day can't tell you that I know which medicine is always exactly the best medicine to start first in which patient.
Okay, let's talk about those medications.
Yeah, yeah. So, I'll try to avoid any brand names, in my discussion here. But there's 3 categories of medications that can be used. You're bringing up is the largest class of medications that's used, and also that has the greatest number of different members of the class are called somatostatin analogs. And what that is that there's actually a naturally occurring hormone in the human body called somatostatin. And, I'll just back up. Maybe it's too pedantic for the audience, but I assume this is an audience that really wants to learn a lot about acromegaly and growth hormone. I quickly sneaked in a little bit earlier that another word for growth hormone is somatotropin. So that's just the same hormone has 2 names. So somatotropin is the hormone, growth hormone. So somatostatin, if you think of it, statin stat mean, means to stop something. So is the hormone that stops growth hormone. So in our body, we actually have a natural hormone that puts a brake on growth hormone. And somatostatin analogs are a class of medication that have been around since the 1980s, believe it or not, that are analogs of the natural hormone somatostatin. They're a little more potent and longer acting than the natural hormone, and that's why they're used. The oldest example in this is something called octreotide, for instance, and then other members have come out, lanreotide, and so on and so forth, all the way until a few months ago. The latest drug in that class, called paltusotine, has been, come out, and who knows what we'll see in the future. So these are a class of drugs that, that really what sets them aside, I think, and makes them used first line to treat acromegaly is they have the greatest effect to shrink any tumor. So they can shrink residual tumor, or if they were treated primarily up front with medication. Uh, However, their ability to control IGF-1 entirely to normal, maybe only around 50 to 60% of all patients with a single, drug in that class are able to completely normalize their IGF-1 level. So it is still in the guidelines listed as the most commonly considered drug to use first. Um, but there's a large group of patients who might not respond to them completely, and there's actually a small group of patients who don't respond to them at all, which might bring us to the other two classes very quickly. And then, I don't know that this isn't a pharmacology discussion today, but maybe since that's my particular area of expertise compared to some of your other guests, since I'm the medical doctor and not the surgeon, I can talk more to it. There is a class of medications that's been around for a long time called dopamine agonists. And the classic example in that class is a pill called Cabergoline. And it's quite inexpensive compared to the other drugs like the somatostatin analogs. Has a very good side effect profile, and cabergoline and dopamine agonists are used very commonly to treat a much more common type of pituitary tumor called a prolactinoma, a prolactin secreting pituitary tumor. So endocrinologists are very familiar with that drug. And success rates with that drug are a little bit less than with somatostatin analogs, and certainly tumor shrinkage is less with it as well. So therefore, guidelines recommend oftentimes using that drug perhaps in milder cases where the IGF-1 is only a little bit above the target, or also maybe as an adjunct. So it's a very common combination where, let's say, an individual was treated first with that somatostatin analog class of medications, which, by the way, as I mentioned, are somewhat more expensive and oftentimes are injections, though, an exciting development now is that we have oral agents in that class too. But, one can add the dopamine agonist, the cabergoline, to the somatostatin analog. And let's say if you hadn't gotten quite to target, then that gets you right there where you want to get to target. And then lastly, just to be, completely comprehensive with the review, the third class of medications is a class called a growth hormone receptor antagonist. So I know that's a mouthful, but basically this is a medication that doesn't actually act on the tumor at all. So it doesn't shrink the tumor. It doesn't lower the growth hormone levels. So the tumor keeps making growth hormone. But all hormones in our body only do anything, have any effect, because they go inside our tissues, into the cells, and they act on these things called receptors. So many have likened this to a key and lock sort of phenomenon. So the key is the hormone, and it has to go inside the lock and activate it, right? So the receptor is the lock that the hormone sits in. And so the growth hormone receptor antagonist, which currently there's only one agent in that class, it's called pegvisomant, blocks the growth hormone receptor. So it really has a very high success rate, in studies of lowering IGF-1 and controlling symptoms. Again, if there was some residual tumor left after surgery, it doesn't shrink that. And it doesn't affect growth hormone, but blocks all of its effects. So it's the one downside of that, you might say, why don't you use that, in everyone much more often if it has such a high success rate? It's a daily injection. It's also fairly expensive. Many of these drugs, we can talk about that more if you'd like later, about the cost of living with acromegaly and treating acromegaly. But most of these drugs are really designer medications used for a rare disease state. So they're expensive, but We have great success, with getting coverage for our patients. So it's pretty rare, but it still happens, and it still is frustrating that we can't get coverage. But if we work enough through various assistance programs, etc., most of my patients tell me there's pretty much zero cost to them, and I'd love to hear your experience about that too, since you may be treated with medications. About what your experience has been with the medicines, and especially with the cost, etc. But that's an overview of the three classes of medications and their roles in treating. And it's not uncommon for any patients listening here. It's not uncommon to work your way through these medicines. And another interesting thing to consider is that these medications can have side effects and they're specific to the medication. So it's important that, your physician who's prescribing them be familiar with the drug specific monitoring for side effects. So if, patients with acromegaly, I find, have lived, and you and others can tell me more about this. I'm not, you could, with a number of symptoms for many years. And I find many of them, they've kind of become not big complainers, and they're just kind of used to living with tired and aches and sweats and all sorts of different problems. So they might be putting up with these side effects from some of these medicines. And sometimes when we switch to a different medicine, they don't have that side effect anymore that was bothering them. And I think that's important, for the quality of life of the patient. If you're going to be taking a medicine long term and it's causing you, there's different side effects you can have from these, but a common one is gastrointestinal symptoms, for instance, where you're always bloated and having diarrhea or constipation. It might be worthwhile trying a change or discussing that with your prescribing doctor.
Let's talk a little bit about side effects. I talk to a lot of people regarding side effects with Cabergoline. Do you mind? Are you open to talking a little bit about the side effects with that particular drug?
Sure. Yes, absolutely. I'm happy to talk about, anything about medications. Yeah, I'm just trying to avoid talking too much about any particular drug under a brand name, etc., for, obvious reasons. We don't want to be promoting any particular drug over the other, but an honest discussion about each drug is very important. So, all of the drugs used to treat acromegaly, I have to, and as you know, I treat many other disorders, and I see all sorts of patients who are on all sorts of medicines. One thing I have to say about acromegaly medicines in general, all three classes, is they're generally safe drugs. So these side effects that I'm talking about aren't like terrible. You know how there's some drugs like, and I don't want to name too many, but other diseases I treat, um, there's some drugs that, yeah, it's pretty safe, but every once in a while it can completely blow out your liver, and one out of 1,000 people might need a liver transplant. So the acromegaly drugs are clearly not like this. So these side effects are transient and usually get better upon stopping the drug. So that's one thing we need to be clear about. And with cabergoline, we have a lot of experience with cabergoline because, as I mentioned, it's used to treat another more common type of pituitary tumor. And so most patients tolerate it quite well, but a significant number of patients list various side effects. There's so many, but there are things like feeling tired, dizzy, nauseous. For that reason, sometimes I tell patients to take it at bedtime if that's the sort of symptom they have. I've seen quite a few patients tell me they have constipation on that medication. Most of the time, if they stick with it and we adjust the dose, the side effects get better over time. But there is a group of patients who, after, trying for a couple, 3 months, who will tell you that I just, this is just unbearable. It's not getting better, and I'd rather move on to something else. And a couple months is usually, enough time to tell also if it's working, if it's lowering the IGF-1 levels and improving the symptoms. With cabergoline, I know this might be interesting, but the single most severe side effect of, any of the medications could be a very rare cabergoline side effect. Cabergoline, as I mentioned earlier, is a dopamine agonist. So it actually activates a neurotransmitter in our brain called dopamine. It also works on another neurotransmitter called serotonin. So anyway, long story short, it can occasionally trigger or worsen underlying psychiatric symptoms. And, we've seen this occasionally. So I tell people always about this, that it's pretty rare, but if you start hallucinating or very depressed or anxious, um, obsessive compulsive behaviors, including gambling, have been reported. I've seen maybe one or two cases like that. So those sorts of things, obviously, we tell people to stop it right away, and those things get better, upon stopping the medication. They're not doesn't trigger a forever sort of a problem. But those are rare side effects of cabergoline that we're aware of. But again, most patients, I would say 80% or more, really report no side effects or very minor side effects that are self-limited, meaning they just get better on their own.
Thankfully, throughout my journey with acromegaly, I have not had any side effects on any of the medications that I've been on. Cabergoline early on was one of them. Thankfully, um, I've hadn't not had any problems of any sort. Let me ask you
That's
this:
wonderful.
how important is long-term hormone monitoring after the pituitary surgery or radiation for patients?
Yeah, I mean, it's very important, and so there's 2 aspects to this. So, since you mentioned surgery and also radiation, there's a short-term and a long-term monitoring that's necessary in both cases. And obviously, since we're talking about acromegaly, I think our audience realizes that we're going to be monitoring growth hormone and IGF-1 levels for the effectiveness, right, of the treatment to see if we've lowered them to normal. But what we also have to keep in mind is both surgery and radiation have a significant risk of also causing collateral damage to the normal pituitary gland. Now, remember that these acromegaly tumors, these growth hormone producing tumors, grow out of a normal pituitary gland. So they're, right up upon, embedded within, or next to the normal pituitary, which has a very important job to do to make 6 or 8 other hormones and regulate important body functions. So it's possible that after a surgery or after radiation treatment to that area, people can develop hypopituitarism, an underactive pituitary. And so we check people early after pituitary surgery because the surgical effect is very quick. Within a few weeks, if you've sustained damage to the normal gland and have low hormone levels that need to be replaced. It's very important for our audience to know that radiation is quite different. So, any person who's had radiation to the brain, especially to the area where the pituitary is at, should have their hormones monitored for many, many years because the hormone deficiencies can start 5 years or even more after the radiation. And so, it is important to have periodic monitoring with labs, preferably with an endocrinologist, because the interpretation of pituitary hormones is also quite complex and is somewhat counterintuitive for people who aren't familiar with it.
You have said a mouthful. I am very excited right now about this conversation. You have enlightened me, and I'm sure a lot of the viewers, on a few different aspects. Let's get into the cost of living with acromegaly. We have mental cost, we have physical cost that we pay. Let's get into the financial side of it that you mentioned and the cost of some of these medications, if you don't mind bagging up and going down in that direction a little bit for me.
Sure. Yeah, and I'm sure there must be studies. I have to admit that I'm not as up to speed on them, where some people have published in the literature the cost of living with acromegaly or treating acromegaly, and even done comparative cost effectiveness studies. It's an area that I don't know numbers that I can quote with, and it would be interesting to look at. But yeah, it really is, a condition that I can turn it back on you and ask you that if a person didn't have health insurance, how would you, not just the drugs to treat acromegaly, but all these things we've talked about, right? The lab monitoring. We haven't even gotten into the points that, patients oftentimes have other problems, which we could talk about because of having acromegaly. And they might need to see other specialists that have other procedures, other tests, other treatments that all add up. And so, it really is something that I think is, when done correctly and, even just by the modern standard, that the costs add up. And as I mentioned that, outside of cabergoline, which is relatively inexpensive, all of the other medications being quote unquote designer medications, their list prices are quite high. Again, fortunately, maybe because acromegaly is considered a rare disease, I find that we're able to find ways to get coverage for our patients. The manufacturers of many of the drugs have just amazing patient support programs, copay assistance programs. The only group of patients I'm aware that don't qualify for that are Medicare patients, for which there are some other workarounds, including various organizations that provide grants. And as of last year, Medicare capped out-of-pocket costs for medications, and that's helped quite a bit because I had faced a couple of cases where I just was having a hard time um, getting medications because of price.
For us living with acromegaly, it seems to be the gift that keeps on giving. You treat hypopituitarism and you also treat Cushing's. There's been patients that I've spoken with who've been misdiagnosed with Cushing's, or maybe in the beginning have been told, well, I think you have acromegaly or Cushing's. Can you get into a little bit about the hypopituitarism and the Cushing's and how they all relate to each other?
Yeah, these are all disorders of the pituitary. Beyond that, they really shouldn't be confused too much by someone who's familiar, with these conditions. I could imagine that perhaps, the reason that people might be confused is the interpretation of lab tests can be difficult. And, Cushing's is caused by an increased cortisol production. And acromegaly, as we've discussed quite a bit today, is because of increased growth hormone production.
And
And so there could be.
Dr. Cargi, I want to say these are doctors that I'm talking about
Right. Yeah,
who was
absolutely.
exactly.
And even endocrinologists, and so I mean, I don't want to share too much, but I saw a patient yesterday, with a pituitary tumor and Cushing's, but the patient had a high IGF-1. And you could see how, they could think that that person could have acromegaly. They're two completely different disorders, and so but it's because you can have a high level of these hormones for many reasons. The actual diseases are rare. So I would venture to say that if you just went out there and checked everyone's cortisol and everyone's IGF-1 level, the vast majority for both, 90% or more that come out high, according to what the lab report tells you, don't have a pituitary disease and don't have a pituitary tumor. And it's just because, as I alluded to a little earlier, these hormones are dynamic systems and they're secreted in pulses, and they can be high due to different reasons. I mentioned, stress, exercise, fasting, and it's a little bit different for cortisol and growth hormone. But understanding and being able to interpret these in the clinical context takes quite a bit of experience. And even though my extreme interest in this, there are cases that stump me. And so there are cases that still stump me. Now, one thing I can say, I guess, so because we're so focused on acromegaly, so I mentioned that, I saw a patient and their IGF-1 was high, and, and I don't think they have acromegaly, but I know they have Cushing's. You might say, how do you know, this might be something, that the audience would be interested in. So if you see a person who has a high IGF-1 level on a lab report, and you say, how do you know that, they do or don't have acromegaly? We haven't gotten to this at all today yet, but the gold standard test still to diagnose acromegaly is something called a growth hormone suppression test. And so in endocrinology, we have a mantra. So if you think a gland is overactive, try to suppress it. And if you think a gland or a hormone is underactive, try to stimulate it. So what we do, you may and others may not have heard of this word. I used the growth hormone suppression test, but the word that's used more commonly is an oral glucose tolerance test. And this is because hormone systems work in negative feedback loops. So, I think you might work in areas related to engineering and others might, be interested in that. So one of growth hormone's roles, I don't know if you noticed, I told you earlier that the reason we make growth hormone is that when we're fasting, sleeping, and exercising, our body makes pulses of growth hormone. Well, if you think of that, what does our body need when we're hungry, when we're sleeping, and we're exercising? It needs more energy, right? Because it needs more glucose. So growth hormone increases blood sugar. It's very and if you give someone sugar, glucose, it should lower their growth hormone. So what we do is we have a patient come in and drink a glucose drink, and then we measure their growth hormone level. And any person who drinks a glucose drink should their growth hormone should go virtually very close to zero. But if it stays high, despite trying to suppress it by giving the natural factor that should shut your growth hormone off, that suggests what we call an autonomy, sort of like an autopilot secretion of growth hormone. That's how a tumor would secrete it, because tumors don't care about glucose or normal secretion patterns. They just keep making the growth hormone all day, all night. So maybe I said a lot, but the IGF-1 is a very useful test to diagnose it, and in most patients it's enough. But if there's any question about the diagnosis, you'll see many patients will have an oral glucose tolerance test. It's usually for people of milder IGF-1 elevations, and we're not 100% sure of the diagnosis. We'll do that. And that is what we call the gold standard test for the diagnosis of acromegaly. So again, this becomes quite complex. But again, it shows where if it's not a slam dunk case, so yours, I don't know you that well, Tony, but what you're telling me, if someone comes in with an IGF-1 of 1400 and various, physical features and symptoms that suggest acromegaly, you don't need to do that gold standard glucose test. It's obvious. There's nothing else they could do. You just do the MRI, and I'm sure when you do the MRI, I've heard you tell your story before, to your audience, that they see an obvious tumor there, and so, but if someone, it comes in and they don't have very obvious symptoms or appearance of acromegaly, and their IGF-1's just a little bit high, but not that high, that's where we would do the gold standard glucose tolerance tests.
Yeah, people who know my story, and you just mentioned a little bit of it, I have a phobia of having an MRI. I still do. I did then. I go through a lot getting an MRI. I'm going to have you back, and we're going to get into more detail about that. What gives you hope about the future of pituitary care?
Yeah, I think that what gives me hope in this area is a little bit about what's a little bit disappointing about it. So, prior to my studying pituitary tumors more, I did some work in the area of thyroid tumors. And going back many years now, we know what causes like 98% or so of thyroid tumors. We can do a very commonly done test, which is a simple needle biopsy of a thyroid nodular tumor, and we run a DNA analysis of the genes, and we can find a mutation in a gene that causes the tumor. And more, we can then find treatments directed to those genetic underlying causes. It's very interesting when you study pituitary tumors, and I'm not aware of any other group of tumors, certainly in my field of endocrinology, where there's such a lack of driver mutations of our understanding of the underpinnings of what goes on in the cell, in the genes that triggers these tumors to grow. Interestingly, among the pituitary tumors, arguably acromegaly is the one where we know the most about this, because there's still, a good percentage of them, maybe up to 40%, where we do know, that what the molecular changes are inside the cells that, that might be causing this. But I don't know that that's led to us finding a specific treatment yet directed at it. So I guess, it's a little disappointing that we don't know enough about the molecular underpinnings of the tumor, but that also gives me hope that that's an area for extreme advancements in the future, that we may be able to find targets for these. And then also what gives me hope is all this other technology that's advancing in society. I mean, the fact that, you're doing this podcast, the fact that we have artificial intelligence, I think is going to help us diagnose patients with acromegaly much, much sooner. I really do. And I think what I said in the beginning of today's talk, where when I think back to 20 years ago, that I'm not sure we're diagnosing patients any earlier, I think that in 10 years, I'm not going to say that, because um, there's been many studies of all sorts of interesting things, but even just photograph analyses, our images are being captured by our cell phones all the time just to sign in. And where, that's to be a very simple way of noticing early changes in people's facial appearances that could alert them. Another thing that we haven't talked about is, how do we diagnose acromegaly sooner? And there are a whole host of symptoms that people get. And, you can tell us about your case, about what sorts of things you had in the years leading up to it. But maybe, electronic health records and things where, that help doctors, and artificial intelligence might alert something and say, you've been seeing this patient for the last few years and they've had headaches and sweating and their carpal tunnel syndrome. And they also developed sleep apnea. And individually, these sound very common. I'm sure if you told a primary doctor, it'd say, yeah, like I see these every day. But in the same patient, in an additive manner as these things are occurring, I would hope that maybe, a computer program would pop up an alert and say, test for acromegaly, acromegaly risk score, 60%. And testing indicated, something like that. I really think we're going to see this sort of development. And people might ask, why is this so important to diagnose it early? Uh, Unfortunately, still in acromegaly, at the time of diagnosis, most tumors are large tumors, what are called macroadenomas, and that directly affects the surgical cure rate. So if we can find these tumors, by the time we've discovered them, they've been growing there for on average 8 to 12 years. So they may have gotten to a point where even the world's best, most experienced surgeon can't remove every last bit of it. But if we could discover it at 2 to 3 or at the 5-year mark, I promise you it would be smaller, and the surgical cure rate, the success would be much higher. And then we wouldn't have to be talking about all these medications that are needed to lifelong treatment to manage the residual disease and residual tumor because, we'd have surgical cures in those patients.
If you could leave patients, pituitary patients, with one key takeaway, what would that be, Dr. Kargi?
I would say, obviously, it's a little self-serving, but I would say, have a good relationship with your endocrinologist. Find yourself an endocrinologist that you can follow with, and and if you're not doing well, it's never a bad idea to. There are some centers where there's some endocrinologists who are more focused on pituitary disorders, and there are some nuances, that we can try. I would say most of the time that the patients, general endocrinologists are doing a wonderful, fantastic job. I'm so impressed, by the amazing job that they're doing. But sometimes there are in certain types of pituitary disorders, I think some added value or some things that tricks up our sleeve or things we can try for those of us who are neuroendocrinologists and who have more experience with pituitary patients. We also have access to more things like clinical studies and clinical trials for new and emerging treatments that we can offer our patients. But one thing I'll say, before I leave you to conclude today's discussion is, you had mentioned that you initially saw an endocrinologist that had, only seen one or two acromegaly patients ever. Even just before I signed on to talk to you, and the hour before I signed on to talk to you, I got a call and a text message from two different of my former trainees. I used to be the director of an endocrinology training program, and these people are working in other places. But when they do see something, a pituitary disorder, acromegaly, or something that they don't see that often, they oftentimes reach out to me and run things by me. And I'm sure that that your endocrinologist, that if they hadn't seen a lot of acromegaly, they know people who did. They were trained at a center where they had professors that focused a lot on this. And and we are a very, if you've met one endocrinologist, you've kind of met them all in some ways. We're a very friendly group of people. Like I said, we don't do surgery or anything, so we just listen a lot and talk a lot and think a lot. And so, we'll always call each other and run our cases by each other. And fortunately, we have quite a bit of time. So it's not a field like cardiology or even neurosurgery where there's these emergencies usually. So, we can always reconsider our approach to a certain patient and, try a different avenue of treatment, consider a different diagnosis. We have a little time to get things right. And we like to talk to each other as a community. So, though, you presented me as as an expert in my field, I still, oftentimes there's people more experienced and older than me that I frequently reach out to them and ask them questions and run cases by them. And most endocrinologists do that. So, my suggestion is to find yourself, if you're a pituitary patient, an endocrinologist. Fortunately, most other physicians aren't that well equipped to understand and treat pituitary disorders. Even if the primary doctor is well intentioned, and sometimes I've seen, I don't want to elaborate too much on it, but I've seen where they can, make good mistakes with good intentions. It could, because the interpretation of hormone levels is quite different. If you have a pituitary problem than if you have any other problem. The pituitary is the command center, sort of like the thermostat of the body's hormones. So if your thermostat is broken, it becomes very difficult to know what your temperature is. And the way we assess the hormone measurements is a little bit more complex in a pituitary patient than, let's say, in a thyroid patient, for instance. And that is a common area where I see other doctors have challenges, but endocrinologists don't.
This has been an amazing conversation. You can talk about endocrinology and acromegaly for an unlimited amount of time, I can tell. It seems
Yeah,
you get
I'd,
so
I'd coined
excited,
some
and I'm
terms,
excited
Tony.
talking to you.
In a lecture once, I used to give the lectures to the students and the endocrinology trainees and fellows, and that I said that I suffer from a condition called acromania or acromegalophilia. That I'm so interested in the topic, and we can always even have talks. It's such an interesting topic. Maybe one day we could talk about the history of going back to David and Goliath. And sometimes when I travel the world, and I like to travel, I find all these very interesting stories of, famous people in different countries in Ireland and Puerto Rico, of people with acromegaly, especially with gigantism, that are well known in those societies. So it really is a topic that, deserves a lot of discussion. So anytime you'd like, I'm happy to talk to you more. And I'm just really so glad that, you've taken up on this torch to help the community out there to talk about this very important and unfortunately, underserved and underdiagnosed group of patients that need more attention. So thank you.
Dr. Kargi, I want to thank you so much for sharing your wisdom and your time today and helping bridge the gap between medical science and patients' understanding, as well as I want to thank you for talking acromegaly with Tony. It's been a pleasure having you today. I'll close with this. Conversations like this remind me that behind every diagnosis, every lab result, every treatment plan, there are real physicians who care deeply about their patients. Whether you're living with acromegaly, navigating hypopituitarism, managing Cushing disease, growth hormone deficiency, or facing a pituitary diagnosis, I hope that today's conversation gave you clarity, confidence, and maybe even a little peace. What stands out to me is this: pituitary disorders are complicated, but patients, we aren't. We just want to feel better. One thing I always say is this: it isn't all in your head, and your symptoms deserve to be taken seriously. However, understanding your condition changes the way you walk into your appointments. It changes the questions you ask. It changes how you show up for your own health. If you found interest in this episode, drop a comment, share it, like it, hit that subscribe button. You can also follow me on all my social media platforms. Thank you for watching. Until next time.